Hello, good morning. We'll continue with the burns, which is an important topic regarding the exams and also a common clinical occurrence. In the last class, we have seen the definition of the burns, that is coagulative necrosis of the epidermis and underlying tissues. We have seen. We have seen how the burns is classified into first degree, second degree, third degree, and fourth, and also superficial and deep burns. And what is our primary aim in the case of major burns? Again, to recall, to prevent early death due to renal dysfunction, we have to maintain fluid and electrolyte balance. That is the most important thing. Care of the wound comes later. In the last class, there are few questions asked. Even today also, if you have any queries, please type in the box. That will be answered at the end of the session. One question last time asked was how the cold water decreases the depth of the burn. There are two mechanisms. One is by reducing the temperature of the burning agent. One. Second, by slowing down the delayed microvascular damage. By these two mechanisms, cold water helps in decreasing the depth of the burn in a case of superficial or partial thickness burns. Another question is, does it produce hypothermia? That will be answered during the course of this lecture. GIT corrosive burns, what is the first aid? That is another question. In fact, when you see the burns definition, skin and underlying tissues are most commonly involved. GIT corrosive burns doesn't come under today's topic. That will be covered during the GIT topics. But anyhow, we'll just go through the basic points. Corrosive burns are caused by alkalis or acids. Commonly, this sodium hydroxide, caustic soda is commonly used, acid, sulfuric acid, and so on. So many acids can be taken, either intentionally or by accident. And once these are taken, they produce burns of the mouth, pharynx, larynx, esophagus, stomach. The damage depends upon the type of the corrosive agent taken, the volume, the concentration. Okay. And somebody takes an acid, it produces severe pylorospasm, so that acid remains for a long time in the stomach and produces more extensive damage. Early endoscopy by an experienced gastroenterologist is the primary aid, first aid we have to do it. That is about GIT corrosive burns. Remember, this will be covered again in dealing with the GIT, stomach duodenum. We'll deal with it. Magical numbers. Today we'll answer these magical numbers also. And PARKLAND formula. There are a number of formulas to guide us to calculate the fluid loss during the burns treatment. PARKLAND formula is commonly chosen or most widely used because of its simplicity and ready availability of the crystalloid. Example, ringer lactate, and easy to calculate. But the fundamental thing, you can use any formula. The fundamental thing is to monitor the response to your treatment. The best clinical parameter is urinary output. In an adult, you aim for 0.5 to 1 ml per kg per hour urine output. If you achieve that, your resuscitation and your replacement is okay. avoid underperfusion or overperfusion to prevent renal shutdown. This is the Parkland formula, again to recollect, 4 ml per kg per percent of total body surface area burnt. This is a common formula. Crystalloid ringer lactate. You can use human albumin or hypertonic saline, but this ringer lactate is most commonly used. This again, you get some volume, you divide it into 2 halves. First half 8 hours, in the first 8 hours. Again, it is important to stress that the time slot starts from the time of occurrence of the burns, not from the time of admission into the hospital. That is very important. And second half, you give next 16 hours. Why this delay, you may think? As the time goes on, the capillary endothelium, which was the primary target, is getting repaired. So as the time goes on, the fluid loss will become less and less. Ringer lactate most commonly used crystalloid, that's what we have seen. Human albumin solution or hypertonic saline can also be used as crystalloids. Now coming to the nutrition. In major burns, metabolism can go to up to 200%. That we call hypermetabolism. That is one. On the other hand, there is a catabolism. It may persist up to 1 year. You need more nutrition to match the hypermetabolism, which is increased up to 200%, and also to diminish the catabolism. Nasogastric tube feeds are commonly given if the burns are more than 15%. They help in healing and also stops the catabolic drop. How to give this nutrition is oral or IV fluids plus or minus total parenteral nutrition plus supplemented feeding. By all these mechanisms, anyone or a combination of these, we supplement the nutrition. This helps in increased wound healing. Overall health is decreased. At the same time, the sepsis, infection is decreased, morbidity is decreased. When you come to the enteral nutrition, that is nutrition by oral route, the Canadian Clinical Practice Guidelines, Eastern Association for the Surgery of Trauma, the American Burns Association, British Burns Association, all have one thing in common. They say start as early as possible, preferably before 8 hours in a case of major burns. Start what? Start the oral feeding. Now this early post-burn enteral nutrition, how it helps? It prevents injury to the gastrointestinal barrier, increases blood flow to the GI barrier, decreases ischemic and hypoxic damage, restores microecological balance. And you know, insulin is an anabolic hormone. It increases the insulin secretion so that body gets repaired early. Again, early enteral nutrition decreases bacterial translocation across mucosal intestinal barrier, decreases intestinal permeability so that fluid loss through intestines will be decreased, and it decreases the hypermetabolism drive. Now coming to Make in India, how to do this enteral nutrition. Previously, it was thought there is no role for enteral nutrition because there may be circumoral burns, patient too unwell to take food through oral cavity, oral route. Then we have acalculous cholecystitis, acute pancreatitis, paralytic ileus. Because of these conditions, people are reluctant to advocate early enteral nutrition. Now the concept, our understanding is changed. Now the rule is start as early as possible enteral nutrition, provided there are no contraindications. One, and preferably within 8 hours. That is worldwide accepted now. Now this is Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. This here we got Asia's largest burn unit, 105 beds exclusive for burns and 15 beds ICU. This where they do a lot of research and give us guidelines how to treat in Indian circumstances. Now they developed a feed or a nutritional supplement based on Indian dietary habits. Now 2 liters of supplemented feed over 24 hours. That is supposed to give us 200 kilocalories of energy, and it contains 2 grams of protein minimum per kg body weight per day. Now the feed formula, it is Indianized, buttermilk based. You add sugar 150, 300 grams of whey protein, that is from the milk, either through oral or nasogastric chew. Now 2 liters must be supplemented either orally or nasogastric chew to the patient. This is in addition to the normal diet which he is willing to take, but this is a must, and this gives 200 kilocalories of energy. Infection. Now, how burns patient is susceptible to infection? The first and foremost is they are immunocompromised. We have already seen in large burns, immunity is compromised. One. Second, the skin barrier is lost. So there is a large portal of entry to opportunistic, pathogenic microbes, bacteria, fungi, because there is no defense. In the third route, when they have burns of lungs or GIT, we have seen there is edema. Edema compromises local defense. And there are other infection routes like catheters, tracheostomy wounds, central venous monitors, Foley catheters. All these ads, there are so many sources of infection. Already patient is immunocompromised, do you remember? Rigorous sterile precautions must be taken and swabs taken regularly from the wound. We used to take for every 5 days, because most of the institutions, the burns are taken care by the surgery people. So we used to treat burns in the acute phase also. We take regular cultures and sensitivity swabs from the wound. And increase in a WBC or thrombocytosis means there is increased catabolism. Nursing care, intensive nursing is required, personal hygiene. Now the patient is definitely in danger from the medical and paramedical personnel. For the reasons which we have already discussed, regular baths and showers, bandaging hands and joints, physiotherapy to prevent contractures. All intensive nursing care is required. And wound care, 3 stages, we have assessment, management, and rehabilitation. First degree, as we have seen, the skin epidermis is intact, no dressing is required. Only we give topical, that is local therapy, to decrease pain and also to keep skin moist so that the burn heals, generally within 3 to 5 days. Second degree, daily dressing is required. We have seen superficial and deep, basing on whether papillary dermis or reticular dermis is involved. Third and fourth degree, complete skin is lost. So wound excision and grafting is required. And how to identify clinically is one. First and second degrees, you have capillary blanching is there. Third and fourth degree, when epidermis and dermis is completely lost. The wound feels leathery, no pain, and no capillary filling. That's how we decide clinically. But most of the situations, the burns are mixed. You have some areas superficial, some areas deep. The reason we have already discussed, giving that temperature is constant, burning agent is constant, time exposure is constant. Different areas suffer different burns. Example, we have seen face. Because of rich vascular supply, there is exchange of heat. So face suffers less degree of burns. You take the back, skin is thick, the blood supply is even normal also, just average. Now, in those cases, they have burns, they'll have deep burns in the back. Blisters means commonly they are superficial burns. And the best thing is take a sterile needle, yes, and just prick, though you don't have to peel anything. Just prick, the fluid comes out, the bleb collapses or the blister collapses, and continue the rest of the treatment. This is what we have done. This blister fluid, why you do this is, blister fluid decreases local immune function. It also slows down chemotaxis, slows down intracellular killing, and it is a good medium for bacterial growth. To prevent all these adverse effects, take a sterile needle and just puncture. Antimicrobials. We have seen how a burn patient is susceptible to infection. But immediately after the burn wound is sterile. Because of the heat, all the commensals or pathogenic organisms which are present in that wound, they will get destroyed. As the time passes on, for the reasons we already discussed, the burn wound is susceptible to so many infections. Now, commonly silver sulfadiazine topical can be used, or mifenide acetate, polymyxin B, mupirocin, anything can be used. And synthetic and biological dressings are also used, depending upon particular condition. In full thickness burns, when there is coagulation of the skin and underlying tissues, there is loss of elasticity. Basically, dermis is completely lost. So skin elasticity is lost. So massive edema, we have already seen from intra to extra compartmental, the fluid shift occurs. Massive edema is produced. Venous and arterial flow is restricted. Now, undamaged tissue deep to the full thickness burns become ischemic. Especially this happens in the limbs, upper limb or lower limb. So to prevent muscle necrosis and further damage, you require fasciotomy or eschcharotomy in a case of deep burns. Now coming to the special categories, electrical burns. Electrical burns can be low voltage or high voltage, but if you see the picture, on 15th April 1912, what happened is the Titanic, the ship which the engineers boasted will never sink, it sank in its first maiden journey from Liverpool to New York. Why it sank, you know, they underestimated the glacier. They have just seen only the tip of iceberg. They underestimated how much damage it is causing. So anybody treating electrical burns and underestimating will sink like the Titanic ship. Basically, you ask, the entry wound is very small, the exit wound is small, but they represent only small portion of the destroyed tissue. Throughout the length, from entry to exit, throughout the length, the tissues are damaged. And there is progressive thrombosis. Because blood vessels, they will go into thrombosis. Muscle is predominantly damaged. In full thickness burns, this is most important. And in every burns due to electrical causes, ECG must be taken in the casualty itself. to assess the cardiac damage. Cardiac derangement can occur within 24 hours when the current passes through T phase of cardiac cycle. Ventricular fibrillation and death can occur instantly because this current interferes with cardiac pacing, sometimes associated with myocardial damage, sometimes not associated. But it interferes with cardiac pacing and can produce ventricular fibrillation and instant death. The fundamental thing is there is acidosis and myoglobinuria. Myoglobins are released because of the destruction damage to the muscles. The treatment is you maintain fluid balance, watch the urine output. We need high urine output. Otherwise, these myoglobins will destroy the kidney. They will end up in renal failure. Normally, we have seen the target for urinary output in an adult is, in a case of major burns, 0.5 to 1 ml per kg body weight per hour per day. Now here, you aim for 2 ml. It should be 2 ml per hour per kg body weight. That means high urine output may minimize the damage by the electrical burns. This is a National Burn Center in Mumbai. Sometimes a few years back, when there was an explosion in the HPCL, Hindustan Petroleum Corporation Limited, Visakhapatnam, they suffered major burns. After doing resuscitation here, they shifted few cases to National Burn Center, Mumbai. But unfortunately, none of them returned back to Vizag. They carries very high mortality. Now, special categories continuing, we have chemical burns. Chemical burns may be by acids or alkalis. There are two issues. One, destruction of the skin by the acid or alkali, local destruction. Suppose if sufficient material is absorbed, it may produce systemic effects. So we have to lavage with water, remove the causative agent if possible, or lavage with water. That's all. But phosphorus or elemental sodium may get aggravated by water, but that is extremely rare. A clinician may not be seen once or twice or not at all. The burns by phosphorus, commonly used in defense, military explosives, phosphorus, and elemental sodium in industries. So most commonly they're not seen. So don't worry whether their burns will get aggravated or not by water. You have to do lavage with water. You may say, no, we got alkali burns, we got acid. Don't neutralize with acid or alkali or vice versa, basically. Because they are not readily available. One, there is a waste of time in searching for these neutralizing agent. Two, third is even if they are available, it results in thermogenic reaction and more local tissue destruction. So the best thing, either acid or alkali, whether you know the agent or do not know, you lavage with water. Copious irrigation, that is the mantra. Dry powder, if it is dry powder, you brush off. Irrigation with water, it dilutes chemicals, it washes unreacted agent, and it corrects hygroscopic effect. So water. Special categories, when it occurs in a confined space like a room, in a vehicle, in a train compartment, in a house where it is a confined space, what happens? Here, apart from thermal burns, you have inhalation burns, because carbon monoxide, which is produced, binds with hemoglobin 240 times greater affinity. It binds. And if you see the dissociation, it is extremely slow, 250 minutes off time, off life at room temperature. It blocks the transport of oxygen 40 minutes of life can be achieved with 100% oxygen. That means whenever there are burns in a confined vehicle, confined space, think of inhalation injuries, think of carbon monoxide poisoning, give 100% oxygen, whether there is circumaural burns or not. It can be assumed confined space. And another compound is hydrogen cyanide is also produced. We have two things now, carbon monoxide and hydrogen cyanide. This produces metabolic acidosis and it interferes with mitochondrial respiration. Give oxygen, 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 100%. Now, cold injuries. Hypothermia is defined as core body temperature less than 35 degrees Celsius. It can be acute, commonly happens in industries, mostly liquid nitrogen, or it may be frostbite, not a problem at least in our part of country, may occur in maybe North India, or common in Western countries. There is formation of intracellular ice crystals and microvascular occlusion is happening in a case of frostbite. Commonly fingers, toes, ears. If you see all these, they are supplied by end arteries. You know what is the definition of an end artery? So the areas supplied by end arteries are more liable for this frostbite or injury by cold. Fortunately, damage is slower, more difficult to define, not as acute as a thermal injury. Basically, what we do is you give rapid rewarming, give analgesics, and give time for demarcation between viable and non-viable tissues. That you have to wait. Non-viable tissues, you have to access that part. Viable, just save as much as possible. Now, special categories, continuing the special categories, ionizing radiation. Ionizing radiation can occur in two ways. One is accidental, nuclear plants accident. We have seen in Japan what happens, then Chernobyl, Russia, what happened, Long Island in New York, near New York, what happened in the US, because the accidental, or it may be due to warfare, bombings, war. When it is localized, it produces ulceration. One, because it interferes with blood supply. So ulceration is produced. You have to excise the ulcerated area, give a vascular rigid flap. When whole body is exposed, as in bombings or nuclear plant accidents, you have to give support to treatment. Now, special categories again, burns in a pregnant woman. Long back, when I was in Andhra Medical College, not only we used to cover the topics for the students, we used to do a revision classes. Take the old question papers and select a few difficult questions and give them, teach them. So when I'm going through the question papers in those times, I was really surprised to find this question. Burns in a pregnant woman. It is shocking because I'm sure even MS surgery postgraduates cannot answer that question. As it happened in 2016, the question was given. When I asked my postgraduates what you have written, they couldn't answer. The final year MS exam going surgery postgraduate cannot answer this question. I said, what I'm teaching the undergraduates and you say you have not answered. This is a very tricky question, but some people fancy, they ask the undergraduates. It doesn't matter. But no, even if you don't answer, it is not going to be a problem because it is beyond your course capacity. Now, this is the question asked. How do you manage burns of a 50% in a 50 kg pregnant woman? This is the university question asked for 10 marks. And I don't know what we expect from a undergraduate student. You forget pregnant woman, you write. Whatever you write, either male or female, same you write. No problem. That we accept because it's too difficult. We don't expect an undergraduate to answer this question unless there is a paper leakage. Here in the burns, in pregnancy, more prostaglandins are produced, more free radicals, results in toxicity. It maintains abortion or premature delivery based on the term of the pregnancy. When you calculate the fluid requirement, based on the gestational age, we have to calculate or include the fetal circulation also. And the first semester, say third trimester, not semester, trimester, it maintains preterm delivery. Second trimester is more dangerous, either abortion or preterm delivery, the risk is same. So risk same as a non-pregnant woman. Now, what are the complications of burns? Systemic complications, hypovolemia can occur. We have already discussed how hypovolemia is produced. Blister fluid we have seen, evaporation, fluid loss, intracellular to extracellular. All these things results in hypovolemia. Then infection can occur. Hemodilution, hypoalbuminemia occurs. Low potassium, hypothermia can occur. Ileus, paralytic ileus can occur. That is the one reason why previously they thought enteral nutrition is not advisable. But now recent concept is you allow oral feeds. Now we used to face, before this concept came into light, a humanitarian problem. A burns of major burns, say more than 50%, 60 to 70. We know deep in our hearts, we are not going to save them. It's only a matter of time. So when I used to go for rounds, they used to ask me, "Doctor, can I have a cup of coffee?" Theoretically speaking, those days concept is they have acute dilatation of stomach, paralytic ileus, acute pancreatitis, acute acalculous cholecystitis, circumoral burns. So it is not advisable theoretically. But suppose tomorrow they may not ask you that question. They may not be there. So I said, okay, have a cup of coffee, a limited quantity. So they will have the satisfaction of taking something which their favorite before they die. That is a humanitarian approach, putting common sense before science. And the respiratory problems can occur, pneumonia, pulmonary edema can occur. This pulmonary edema, by interfering with the local immunity, can compromise the respiratory function. And one cause for these infections, increased infections. Acute tubular necrosis can occur in the kidney. Local complications can occur. We have seen how this eschharotomy you have to do, and scarring may result in keloids or hypertrophic scars, or this scarring in the long term, maybe after 10 or 15 years, burn scar. They are notorious for causing this Marjolins ulcer. You know what is Marjolins ulcer? Read in pathology. Marjolins cancer classically described in a burn scar. Marjolin is from France. So he described long back these Marjolin's ulcers, and contractions can occur. In any wound contraction is physiological wound contraction. Whereas wound contractures are pathological. Now what happens if there is wound contractures? Basically, when the wound contractures occurs in a case of deep burns only. Superficial burns or partial thickness burns, no contractures occurs. But in deep burns, contractures are the late complications of the burns. Now, this is what happened. While working in another college government hospital, I told you we used to treat the burns patient. When I was transferred there in my unit, this patient is there. You see, there is no neck because of the deep burns, whole wound is contracted, contractures. Now she cannot open the jaw. See, this is another case. You see the arm contractures and also finger deformity and also the burns. Healed burns means they are all superficial. Here, deep burns producing contractures. Virtually there is no neck. We'll have a close-up look. See, virtually there is no neck. So when I found these cases in my unit, I said, we'll treat it. My unit people surprised, what this? They're the plastic surgeon's domain. I said, nothing like plastic surgeon's domain. We'll do it. Then they said, sir, nobody has ever done it. That is another indication. We'll do it here now. So we prepared and we have done first time the release of the burns contractures. Now see, there produces lot of technical problems. How to give anesthesia. They cannot put endotracheal tube because they cannot extend the neck. They have given almost 3 hours. I still thank the anesthetists at that hospital who are present at that time. They trusted me. They gave almost 3 hours. They maintained intravenous anesthesia and analgesia. A risky proportion. If suppose there is a respiratory problem, they cannot put an endotracheal tube. They cannot secure the airway. But still we have taken a chance. And once the contractures are released, it has taken 3 hours for me to release the contractures. Then they can have this endotracheal general anesthesia. Now, be relaxed. You can have all the time in the world to repair them. So this can be done by surgeons if you have interest. Don't say only plastic. We don't call plastic surgeons. Now coming to the magical numbers. What is this magical numbers? All are in minutes, 60 minutes, 10 minutes, and 20%. Okay. Suppose somebody suffers a burn, especially this applies to the limbs. So the burn part must be cooled within 1 hour. It is something like your golden hour of a trauma, major trauma. The earlier you intervene, the better will be the outcome. So within the 1 hour, you must cool it with water. And abdomen or head and neck, you put a gauze piece and pour cold water. Don't dip somebody suffers a head and neck burns. It comes 9 plus 1, 10%. Maybe less than that, okay. Don't dip the head in the water, please. Don't take my word in letter and spirit. Okay, figuratively I'm telling, cool it in water, dip it in the water. Upper limb, lower limb, you can dip it in water, not head and neck. So within 1 hour, that's one. Second is, the cooling must be continued minimum 10 minutes. That is 10. Minimum 10 minutes must be continued. And acid alkali burns, that is chemical burns, it must be continued for 20 to 30 minutes. But minimum 10 minutes. Then 20 is percent. If the body surface area burnt is more than 20%, don't go for cold water therapy. It results in hypothermia. So last class one, somebody asked about hypothermia. We'll apply cold therapy or cool water therapy. We'll cool the wound only when the burns is less than 20% of the total body surface area. More than 20, we don't do it because it may result in hypothermia. Now, outcome depends upon total percentage of the body surface area involved depth, whether it is superficial or deep. Inhalation injury, already we have seen, inhalation injury can cause the high mortality. Prevention, how to prevent burns, health and safety regulations, educating the public, legislation. We have seen how the pressure cookers and gas stoves are modified with more safety precautions, and smoke detectors, education. And again, in the West, most of these geysers, hot water geysers are fixed at 60 degrees Celsius. That is fixed. You have seen recently also, central government is fixing that air conditioners, a similar way. It starts from 24 only. All the new generation air conditioners, 24 degrees only. You cannot have 18 or 16. That is going, that is gone. So in the West, most of the geysers, not most, almost every geyser is hot water geyser is fixed at 60 degrees Celsius. It's fixed. And legislation. These are the few methods to prevent the burns. Basically, 99% burns are preventable. Either accident or intentional, they can be prevented if you have a good health and safety regulations, educating the public, and some legislation. Now, any questions, you can type in the box. Hello, anybody? Any questions? See, the question is, what is a suitable axial flap for third-degree burns? In fact, that is not the question for you. Nobody will ask you unless you have special interest in only after MS surgery or MCH plastic surgery, we'll answer that question. Not for an MBBS undergraduate, that is beyond, nobody will ask you. When and how, next question is, when and how curling ulcers occurs in a case of burns. Major trauma, we have seen that when burns, major burns involve more than 25% of body surface area, we have seen there is fluid loss and mucosal erosions away from the burn surface. That is, body acts as a whole, reacts as a whole for the insult, for the injury. That's how curling ulcers are produced. So we are preventing or minimizing by giving antacids, 1, proton pump inhibitors, 2. Third is early feeding. Maybe within 8 hours, we'll start the feed. That's how they are taken care of these curling ulcers. Will you advise insulin for moderate to severe burns as a routine? Generally, we don't advise, but maybe I don't know what is the protocol they follow at the Vardhman Mahavir Medical College, but generally we don't advise unless there are major burns and the situation is critical. Basically, why we use increase insulin is, give insulin is to increase the metabolism, increase the anabolism, and decrease the catabolism. If you take care of the burns wound and also enteral nutrition, insulin is secreted naturally, and there is no need for giving by the extraneous route. Is there any contraindication for crystalloids in a patient with mineral excess syndrome with active cirrhosis? Yes, you have to take care of the comorbid conditions also. Comorbid conditions, whatever it may be, either liver disease, renal disease, diabetes, hypertension, cardiovascular disease, you have to do a suitable modifications, keeping in mind the comorbid medical conditions. Naturally, you have to take care. Now, any more questions? If there are no questions, we'll close down. Any questions? Ah. Is there any mineral contracted crystalloid that we have already answered? What is the most common organism? It all depends, you know. In fact, in major institutes, they uh, they have this antibiogram every month in a major institute like AIMS Delhi, which is the oldest and 50 years old nearly. You can't just simply prescribe whatever antibiotic you comes to your mind. They assess the microbes or bacteria present in that institute and to which drugs they are sensitive. And this is constantly updated every month. You are supposed to choose some antibiotic basing on the organism of the local prevalence. That is called antibiogram. This is done at microbiology and a form trial, clinical aspects of this, they are doing it. So it all depends upon the what you get in the culture. Commonly we give, as I told you, in the early phases, the burn is a sterile wound, one. Second thing, then early burns, there is sterile wound that will get contaminated as the time passes on. That's why I said we take a regular culture and sensitivity. Every 5 days, every fifth day, we'll repeat the culture and sensitivity. We'll use appropriate antibiotics. Why tetany occurs in filigree burns? In electrical burns, why tetany occurs? Basically, tetany occurs when you come in contact with any dirty surface. So, tetanus toxide is given as a prophylaxis, or you boost up your already immunity. That's why it is filigree. I do not understand what is this filigree burns. I do not know what is this. I cannot follow filigree burns. Anyway, in electrical burns or any burns, we use this tetanus toxide as a prophylactic because we don't want another added problem by some contact with a dirty electrical equipment, rusted dirty electrical equipment to gain tetany spores gain into the entry into the body. So commonly it is given a tetanus toxide is given. And never underestimate the electrical burns. There may be small entry wound, small exit wound, but remember the whole track in between, it is necrosis. As progressive thrombosis occurs, the muscles will get damaged and destroyed. You'll have myoglobinuria, renal shutdown, early death, apart from cardiac ventricular fibrillation and interfering with normal cardiac pacing. All this occurs because of this electrical activity. It all depends upon the high voltage or low voltage, whether there is associated cardiac damage or no cardiac muscle damage. Common side for curling ulcer, that is, everybody knows it. That doesn't warrant an answer. Next. Okay, if there are no questions, we'll close down the session.